What is the Healthy Livers, Healthy Lives Coalition, and why do we need it?
The Healthy Livers, Healthy Lives Coalition was launched earlier this year by EASL, along with the American Association for the Study of the Liver Disease, AASLD, the Latin American Association for the Study of Liver Disease, ALE, and APOSL, the Asian Pacific Association for the Study of the Liver Disease. It brings together the four main professional liver societies. The Society on Liver Disease in Africa, recently formed, will soon be invited to join us. And the idea is to create this coalition to raise awareness about one of the most pressing and prevalent liver diseases facing us today. That's steatotic liver disease, and particularly metabolic dysfunction-associated liver disease.
What did Healthy Livers, Healthy Lives achieve so far, and what is its ultimate goal?
Since our formal launch in October 2022 at the Wilton Park think tank in the United Kingdom, we've launched a global action priorities agenda published in the journal Hepatology, and a global research priorities agenda published in the Journal of Hepatology. We launched the latter at the EASL Congress in Vienna earlier this year. We launched the action agenda at the EASL meeting, the Indian National Association for the Study of the Liver, and then again launched it at the ALE conference in Bogota in late August this year. We're trying to bring the research and action priorities that were developed by a large global multidisciplinary group of experts to the major meetings around the world, starting with the liver meetings and then branching out to priority areas like endocrinology, meetings addressing obesity and lifestyles and nutrition. So our number one priority has been to get the field united around this global roadmap. The other big activity we've held was a side event at the World Health Assembly held at the EASL Secretariat headquarters in May this year, where we engaged with experts from the World Health Organization, had ministers of health, other policy and decision makers, and representatives from our field, but importantly also from endocrinology, cardiology, pediatrics, primary care, all to unite around the importance of getting steatotic liver disease and specifically MASLD onto the WHO agenda.
How can the work of Healthy Livers, Healthy Lives help improve diagnostic pathways for SLD?
The Healthy Livers, Healthy Lives Coalition is set out to raise awareness around steatotic liver disease. Now, regarding MASLD multidisciplinary pathways, because we're a large group of experts that include not just liver health, but also endocrinology, primary care, addiction specialists, we can start to foment and develop and raise awareness about which models of care work best and where. So it's about raising awareness outside of our field, and that includes not just policymakers and decision makers, but also hospital administrators and others who can facilitate the development of models of care that are patient-centered and better fit for purpose to get the right people to the right care providers.
What is the landscape of diagnostics for steatotic liver disease?
In the last 2 decades, we have seen a lot of development in non-invasive testing in steatotic liver disease, especially for the diagnosis of advanced fibrosis, but also importantly for prognosis. And this has been from studies investigating both steatotic liver disease in alcohol-related liver disease and in metabolic-associated steatotic liver disease. Now, if we look at the biomarkers, we can divide them into two: the blood-based on one hand and the imaging-based or elastography-based on the other hand. For blood-based, I like to divide them into indirect and direct markers. Indirect markers are indirect because they do not reflect fibrosis per se. They rather reflect liver function and liver inflammation. The prime example here is FIB4 or fibrosis 4 index, which consists of AST, ALT, platelet count, and age. The direct markers, on the other hand, typically contain markers of fibrosis measured in blood but derived from the liver. This can be the ELF test or enhanced liver fibrosis test, which contains hyaluronic acid, TIM1 and P3NP, or it can be ProC3, which is a type 3 collagen propeptide. For the imaging-based markers, this is elastography, and they are, for now, the most accurate markers. So elastography can be measured either by magnetic resonance, MRE, or it can be measured by different types of ultrasound techniques, typically vibration-controlled transient elastography, or point shear wave elastography, or two-dimensional shear wave elastography. The limitations of especially the ultrasound-based elastography methods is obesity, unfortunately, and this has an impact on patients with steatotic liver disease. So if you as a clinician are having an elastography result in a patient with obesity, then be aware that the diagnostic discriminatory accuracy for advanced fibrosis is lower than in lean patients.
How are non-invasive tests being used in practice?
Many of these new non-invasive tests have penetrated into clinical practice. I mentioned FIB4 as an example, which is now a robust marker of especially the absence of advanced fibrosis. So FIB4 has a good negative predictive value. Liver stiffness measurement using vibration-controlled transient elastography with the equipment FibroScan is also widely validated and widely used in clinical care. The Baveno 7 consortium has recommended the so-called rule of 5. So if you have a patient with a liver stiffness of 5, this is normal. If you have a patient with a liver stiffness of 10, this can be used to rule out compensated advanced chronic liver disease, while liver stiffness of 15 kilopascal rules in compensated advanced chronic liver disease, and liver stiffnesses of 20 and 25 using vibration-controlled transient elastography denotes an increasingly higher risk of first decompensation and liver-related mortality. So personally, I like to use 8 to 10 kilopascal to rule out advanced fibrosis, meaning this is not a patient that necessarily needs to be followed in hepatology specialist clinics. And I use 12 to 15 kilopascal to rule in compensated advanced chronic liver disease. However, especially for ultrasound-based elastography, there are causes of false positives, typically not being in a fasting state, hepatic inflammation, cardiac right side failure, or hepatic edema, and obstructive cholestasis. And so these causes need to be ruled out to be sure that you have a true positive liver stiffness measurement result.
What are the challenges and opportunities associated with stratification pathways?
Now, most of these non-invasive tests, both the blood-based and the imaging-based, have been tested in secondary or even tertiary care populations. So their intended use is not for now in primary care populations. However, we are starting to use the tests. And fortunately, there are also now large population-based studies showing how non-invasive tests can actually be used in referral pathways on selecting the right patient for specialist care. And in that sense, it for now looks like FIB4 is a good first marker to rule out advanced fibrosis. We must know, however, that FIB4 is not perfect, so there will be cases of false negative results, patients who do have advanced fibrosis, but a FIB4 below 1.30, which is the rule-out cutoff. So the important thing here is to make sure that the GPs know that in a patient with steatotic liver disease, where the risk factors for liver for steatotic liver disease prevails, then FIB4 needs to be retested after, for example, 1 or 2 years. Now, the problem with the indirect markers of fibrosis, including FIB4, is they have a high number of false positives. So there have been studies in populations consistently showing that elevated FIB4s above 1.30 is present in anything between 1 in 4 to 1 in 3 of the entire population. And so if all these people were referred to specialist care in hepatology clinics, this would obviously mean a lot of resources spent on diagnosing patients which basically would be healthy for the major part of the people referred. So what we are doing instead is now working on introducing a second test that can more effectively rule out disease in those with elevated FIB4s before referral to secondary care. And I think this type of sequential pathway will lead to more cases being correctly classified as having advanced fibrosis due to steatotic liver disease. And what we are hoping is that we can now show that we can improve management for those people that are referred with early stages of cirrhosis or advanced fibrosis. So the hope is, and we are not there yet, but the hope is that in the future, we can show that early detection of advanced fibrosis in steatotic liver disease patients actually improves management and thereby reduces liver-related morbidity and mortality.